Hello, everyone. We're just going to give a few more minutes for all of the attendees and speakers to log on.
Hi,
Dr.
Julia.
How are you?
Doing well. Thanks for including me.
Oh my gosh, thank you for speaking. So we're just going to give everyone a few more minutes to log on, and then we'll go ahead and get started.
Super.
All right, so we're going to go ahead and get started now. All right, so hello, everybody. Thank you for coming and welcome to the STEM Connects Medicine and Healthcare Career Panel. I'd also like to thank all of our speakers for coming today. And due to scheduling issues, our second and third speakers will be coming closer to their speaking time. My name is Julia, and I founded STEM Connects last year with the goal of educating, empowering, and inspiring high school girls to pursue careers in STEM. I will be serving as the moderator for today's panel discussion, which will feature three accomplished speakers in the following order: Dr. Erica Mayer, Dr. Andrea Bauer, and Dr. Marcella Alsan. Each speaker will talk individually for 15 minutes, and there will be group Q&A with all three speakers at the end. Please use the Q&A feature in the webinar to submit questions, and please feel free to ask questions at any time. Now, I'd like to briefly introduce our panelists. Dr. Erica Mayer is the Director of Clinical Research at the Dana-Farber Cancer Institute. She received her medical degree from Harvard Medical School, as well as a master's in public health from the Harvard School of Public Health. Dr. Andrea Bauer is an orthopedic surgeon and the director of the brachial plexus program at Boston Children's Hospital. She received her medical degree from Columbia University. Dr. Marcella Alsan is a professor and the director of the Health Inequality Lab at the Harvard Kennedy School. She received her medical degree from Loyola University, as well as her master's in public health from the Harvard School of Public Health and a PhD in economics from Harvard University. For more information about STEM Connects and to stay updated about future events, you can visit our website using the QR code or the link here. The address is www.stemconnects.org. So we will begin tonight's webinar with Dr. Erica Mayer. Dr. Mayer is an associate professor of medicine at the Harvard Medical School and director of clinical research at the Dana-Farber and Women's Cancer Center at Faulkner Hospital. She's a medical oncologist focusing on new ways to treat breast cancer. Dr. Mayer graduated from Williams College with degrees in biology and history and Harvard Medical School before completing her residency training in internal medicine and fellowship training in medical oncology. She also completed a master's in public health in 2005. So, Dr. Mayer, welcome to tonight's panel, and thank you so much for coming to speak here. I would just like to take a moment to remind everyone about the Q&A feature that is available through the webinar. And as we get started, I would please encourage everybody to submit their questions. So, Dr. Mayer, our first question for tonight is just kind of a general, how did you become interested in medicine? And that can be from any standpoint or starting at any time in your career. Could you just share a little about your interests and kind of how you develop this career path?
Great. Well, thank you so much for the introduction, Julia, and thanks so much for inviting me to participate in this panel. This is a fantastic program, and I'm so excited to see so many people on the call. So let's see, I can tell you a little bit about myself and my pathway. Once upon a time, I was in your shoes. I was a Windsor student and came to Windsor with lots of different interests. But I'm gonna take these off because they have a lot of glare. What I really loved was I loved science and I loved history. Those were my favorite classes in high school. And so when I went on to college, I continued to explore my interests in those areas and majored in those fields. I was a double major, but I was also pre-med. And so I did lots of things like writing huge research papers, and I did a thesis in an immunology lab and just had a wonderful time doing those things. In the summers, I worked in the research lab in Boston. So I was beginning to get a lot more experience working in a lab, doing investigation, interacting with scientists, and all of it really confirmed my interest that I wanted to pursue a career in medicine. I should add that one of my parents, my father, it continues to be a doctor, and that was something that I grew up with. So just like you, I had a lot of medicine at home, and it was something that I was pretty familiar with and comfortable with. So I'd had experience seeing patients and seeing what doctors did. It is important as one considers this kind of career to really know, like, what is the job of a doctor. So I applied to medical school out of college. And back in those days, many people just like went to college and then they went to med school, and it was like seamless. I actually took a year off. I did a gap year at a time when like almost nobody did gap years, and went and lived in Tokyo for the year and did completely non-medical things, which was super fun and very important to really feel like I had some balance. And then when I was in medical school, it's kind of like being in a candy store where there's like all this stuff that looks really, really good, and you just don't know like which thing you want to pick because it's all really good. I loved surgery. I loved OBGYN. I loved pediatrics. I loved all the things I did. So I found it really hard to, at the end of medical school, where you have to decide what's the next step, what are you going to train in? I found it really hard to pick just one thing. But I ended up focusing on adult internal medicine because it felt very broad. There were lots of opportunities, and I really enjoyed my rotations. I should add that a theme that you'll hear from me, and I imagine you'll hear from my co-panelists as well, is it's really important to have great role models and mentors. And many of the people I met on my rotations when I was at the Harvard teaching hospitals were just these amazing mentors and amazing teachers. And I found it very inspiring, and it helped me kind of shape my career focus. And you know, I gradually gravitated towards medical oncology, which is an amazing and exciting field that ultimately really stitched together my interests in science and history, because it's an area where you can have deep relationships with patients. You can learn about incredibly exciting and cutting edge science, and you can work with amazing, inspiring colleagues. And so it's really been a wonderful place to be. I've been working at Dana-Farber now for 20 years, and literally no day is like the one before. Every single day is new and exciting. There's so many incredibly exciting things that go on in cancer treatment and cancer research. The field has changed dramatically just in the time that I've been doing this, and I get to take care of like amazing patients. So it's been a wonderful path for me. And you know, as I mentioned, I continue to have amazing colleagues, amazing mentors, and role models, and hope to do so moving forward.
Yeah, thank you so much. That's a great short history, I'd say. And so thank you for sharing that with us. So obviously, you're the director of clinical research, so you do a lot of clinical research as part of your job. So could you explain in your words, or your own words, what clinical research is and how is it different from other types of research?
That's a great question. And when we use the word research in science or medicine, it is an incredibly large umbrella term. There are so many ways to be a researcher. There's so many ways to ask questions scientifically about the world around us, about disease, about people. And generally, research falls into a few different categories. In my world, we generally think of three main categories of research. we have what we call wet lab research, which is when we think about people working in a research lab with a bench and they have pipettes and tubes and stuff. That's what we think of with wet lab research. And that's where we're asking some of the most fundamental questions about how biology works, how cells work, why do diseases happen, how can we try to treat diseases. And the things that we discover in that lab can translate or transition into people. And this is where clinical research happens, research involving typically human subjects. What I do is trying to take new drugs and new medicines and test them out in people to see how easy or hard are they to take? How well do they work? Are they effective at treating cancers? Do people do better? And then there's also another kind of research that we sometimes call dry lab research or outcomes research. And that's been an evolving field where we can ask questions looking at big populations and big groups of people and ask things like, well, if people do one thing, does another thing happen? Or if we want to study a group and say who's more likely to have this event happen or that event happen, what characteristics of those people might predict for that? And that involves a deep knowledge of statistics and data analysis. All that math that you're studying is used in these situations. But all of these types of research are very complementary and they stitch up really nicely together. So you can ask very similar questions in all three settings that are asked and perhaps answered in different ways, but they all interrelate. And for me, it all comes together in terms of how do we understand cancer? How do we treat cancer, both in an individual person and in large populations? What I do specifically is we write clinical trials. So we have new medicines. We want to see how well do they work. So we write a trial where we will design a way to offer new medicines to people in a very safe and controlled way. We'll have a very careful way of seeing how the medicine is working, how well are people doing, and then we analyze the results and present the results. The whole process can take a few years, so it's a pretty lengthy thing, but it's a really exciting way in particular for me to share research and discovery with my patients, because my patients are my partners in this process. When we are putting patients onto trials, we're asking them to hold our hand and jump in together and try to discover something new. And for many patients, it can be really exciting to be part of the process and to be a contributor to major advances in cancer care. So it's particularly rewarding, when we get to present new data and we think about all the individual people who contribute to it. It's really a wonderful thing.
Yes, thank you so much for that overview. And of course, especially with clinical research, that patient interaction and connection really is a core part of your daily routine. So on a slightly different note, you mentioned before that, each day's schedule can vary a lot, even day to day. So could you kind of give us a general overview of what your weekly schedule might look like in terms of maybe clinical trials, maybe you have appointments with patients. So just a general overview of your weekly schedule.
Yeah, so many doctors who are working in what we call academic medical centers, so centers that are focused around research and teaching, will be seeing patients or taking care of patients for part of their time, but then the other part of their time might be doing activities like research, teaching, administration, leadership. So for me, I think of myself as a 50-50 person. So about half my time is spent taking care of patients. Like today, for example, I spent the whole day in clinic seeing my breast cancer patients. And then tomorrow is one of my research days. My research, again, doesn't happen at a lab. It happens on my computer. So I'm basically in meetings all day and I'm writing documents and I'm talking to people and collaborating. My calls might be talking to people in Boston. I'm often talking to, one person's in Austria, one person's in Spain, one person's in Korea. We have really a global community of people who work on these projects together. So it's very fun to kind of bounce from call to call, and each one is really interesting, and we're doing something different. One thing I would mention is that our workday doesn't just like stop at 5 or 6 o'clock, but we just keep going. So as I'm sure you see with your parents, we work kind of at all hours sometimes, and that can be quite busy. But it's nice to be able to really get things accomplished, and there's definitely a lot of work to do.
Yes, for sure. So for the next question, what advice would you give to students interested in medicine about how to approach classes or other activities in college or in general, how to determine if a career in medicine is what's right for them?
Well, as you can hear, I'm a big cheerleader for careers in medicine. So I definitely encourage anyone who's even a little bit interested to try to explore. I think something that's very important, as I alluded to before, is spending some time in a clinical setting and seeing what do doctors do, what do nurses do, what do nurse practitioners do, what do physician assistants do. There's so many different ways to be involved in medical care. So it's good to see what all these jobs are and see what might be of interest. It's a little hard to do that as a high school student. It's a little bit more for college students, but definitely something if you ask around, if you ask your family doctor or a friend's parents or someone you meet on your college campus, these are, folks are really excited and enthusiastic to bring someone in for the day to see what's happening. So I think that that's a wonderful way to just start getting a taste of it. In college, I think once upon a time, the thought was if you're pre-med, you have to be a science major, you have to, study biology or biochemistry or something like that. But nowadays it's changed. And really what you want to be doing is just following your passion. And if you really love, Spanish literature and art history, and you also like biology, you don't have to major in biology. You can major in, Spanish history or art history, but still do the prerequisites that you need. Being a doctor is very multidimensional, and of course, there's the science aspect, but there's a deep humanistic aspect. And if that's really what runs deep with you, it's absolutely worth exploring. One finds nowadays that many people who are ending up in medical school do not just go straight from college to medical school, but will do lots of different activities and get a lot of different experiences and exposures that really help you flesh out who you are as a person. And so, I think it's really following your passion and what you feel really interested in. That's, I think, a very nice way to find your path into a medical field.
Yes, thank you so much. Now, this will probably be our last question, but what would you say throughout your entire career, so this can include all the way up to college and medical school, what would you say your greatest success and your greatest challenge has been? And how do you think that has made you view or has influenced your perspective on your career?
Gosh, that's a tough question. I think let's see. In terms of greatest success, I'm really, I would say right now I'm very proud of the research program at Dana-Farber in breast cancer. We are the biggest breast cancer program in the country, possibly in the world, honestly. And we run a huge number of trials. And every time we have one of our big meetings, we have kind of big global meetings twice a year. I'm so excited to see the research work that our group has been working on so hard being presented up at the highest level and really changing practice. So I feel enormous excitement and pride in my colleagues for the work they do. And when I get to be that person doing the presentation and just feeling like you're part of the process moving the field forward. So I think that's really wonderful. I think in terms of challenges, you might hear this from other people, medicine's can be a really kind of busy place nowadays. There's just a lot that is asked of us on many levels of what we do. And, I kind of feel a little nostalgic for the time when it felt a little simpler and we didn't have so many kind of complicated computer programs and pieces of paperwork we had to fill out. And I would love to be able to focus on what's like really important in patient care and in clinical research and not have too much other kind of busyness around. But, times change and we adapt and do our best. So I hope that's what you were getting at.
Yes, absolutely. Thank you so much for all the insights you shared and for all your responses to the questions. I did see a few specific questions from the attendees, but hopefully we can get to those in the group Q&A at 8:35 after the next two speakers. So our next speaker will be Dr. Bauer. Dr. Bauer is currently the director of the Brachial Plexus Program in the Orthopedic Center at Boston Children's Hospital and an associate professor of orthopedic surgery at Harvard Medical School. After graduating with a degree in chemistry from Princeton University, she attended Columbia's College of Physicians and Surgeons. Dr. Bauer then completed her residency training in orthopedics, followed by fellowship training in hand surgery at the Massachusetts General Hospital. In addition to taking care of infants and children with hand and upper limb conditions, she's actively involved in clinical research, as well as teaching students, residents, and fellows. So, Dr. Bauer, welcome, and thank you so much for coming here tonight to speak with us.
Hi, thanks for having me, Julia.
Yes, of course. So, like I mentioned before, you are an orthopedic surgeon. And so I was just wondering if quickly you could explain how surgical fields are different from medical fields, and why did you choose orthopedic surgery, within all the different types of surgery?
Yeah, that's a great question. So, in academics, many doctors in the medical fields will spend a large portion of their time doing research, whether that's clinical research or bench research. Even at very academic places like Harvard, most surgical subspecialists will spend only about 20% of their time on research and the rest of the, or even less, and the rest of the time on direct clinical care. And depending on the surgical subspecialty that you're in, there'll be more or less time that you're in the clinic or office hours. But then obviously every week has to have time to go to the OR. And so we spend a lot more time doing that than other specialties. So that time has to come from somewhere. And so we spend often less time on research than other other medical specialties.
Okay, thank you so much for your response. So in addition, in the United States, less than 10% of orthopedic surgeons are women. So can you share what your experience is being a female surgeon, especially in an orthopedic field? And what advice would you give to the female audience members who might be interested in a surgical career?
Yeah, gosh, there are more female urologists than there are orthopedists. So you guys need to change that. I think, there's a big part of it that has to do with exposure. So most women who go into orthopedics do so because they had a childhood experience that had them encounter an orthopedic surgeon and know what the field is. I think if you just haven't happened to have that personal experience, when you think of doctors, you just don't think of orthopedists, you don't think of surgery. If you've never had surgery, you don't think about it. So certainly things like this are wonderful. There are programs out there to get even middle schoolers interested in orthopedics and engineering. I would say the other piece of it is that as people go through medical school, there's this perception that that surgery, in particular orthopedic surgery, is not for women. And even I don't consider myself to be that old. I'm 43. But when I was in medical school, I had female doctors tell me that I should not go into orthopedics. Over the Zoom call, you guys can't tell, but I'm 5 feet tall and I weigh 110 pounds. That's not the typical orthopedic surgeon. But I can tell you, I did absolutely everything that was necessary to go through an orthopedic residency. And so you can too. And I think that there's this common misconception that the size matters and that there are certain things with orthopedics that a woman wouldn't be able to do. And maybe those things were true 50 years ago, but they're just not true now. And, just like what Dr. Meyer was saying, to think about healthcare beyond being a doctor, I always think about the orthopedic nurses. Back in the day, 40, 50 years ago, when every orthopedist was male, most of the nurses who were getting that heavy equipment together and handing it to them and helping the surgeons were all women. And so there's no reason that women can't be part of this, and it's such a fulfilling career. The patient population that we get to work with, the control over your own time, the ability to be a manager and a leader, because every little OR case, the surgeon is the one who's in charge of that room. It's really a wonderful, wonderful experience and a wonderful career. And so hopefully that's something that over the next generation, you guys will change.
Yes.
So you can all take care of me when I need a hip replacement.
Hopefully that will never happen. But thank you so much for sharing your experience and what it's been like for you as a female surgeon. And so I guess when you were maybe in earlier stages of your career, like medical school or maybe early residency, how did you find female mentors in both the general surgical and orthopedic fields? And how do you think that helped influence, shape, or help your career?
So that brings up a good point because I would say that there's room in your life for all sorts of different mentors. So I just flat out did not have a female mentor until I was in practice, I think. So if I look back at my medical school, there were no female orthopedists at Columbia back when I was in medical school. When I was in residency, there were very few back then. I can think of maybe one that was a little bit influential that, it was very different than it is now. And so I think, I looked for people who were willing to mentor across our differences. And I found really wonderful mentors in the male pediatric orthopedists that were at Columbia. And that led to my interest in pediatric orthopedics and my desire to come to Harvard for residency because of Children's Hospital. And so I think that's something, you can see yourself in all sorts of people, even those that don't look like you. And I think it's also something, I don't know if there are any men on this call, but it also speaks to the importance of, mentors being willing to reach out to those who don't look like them, and also to provide sponsorship and opportunities for people who don't look like them. So my biggest champions were guys when I was in medical school, and that was okay, even though I didn't, we didn't see each other, see ourselves in each other. Maybe I reminded them of their daughter, or they were, just similar personalities, and the relationships worked as mentor-mentee, even though we didn't look the same.
And I guess on the other side of that, as part of your professional life, especially with Boston Children's being a teaching hospital, you do a lot of mentoring and teaching yourself. So can you share with us what this looks like and what might you like the most and least?
Yeah, so I think, mentoring is a very important part of what we do. I really take pride in being a role model in orthopedics as somebody who maybe doesn't seem like the traditional person. I also have a life, I have a husband, I have 2 kids, I have hobbies, to show that this is possible to have a fulfilling career and a life. And I think, I don't know if this is what you're getting at, but I don't know. Do you want me to talk about the, what a good mentee would be like? Is that part of your question?
Or in general, I guess in your experience, what is it like to be a teacher as a surgeon, and what is that experience like?
Yeah, so I mean, the hardest thing that we do as academic surgeons is we operate while somebody else is holding the knife, and that's part of our job, is to make sure that the graduates come out being able to do surgery on their own, and never jeopardizing the health or safety of the child under our care. And so I think that's hard. I think it comes from very clear expectations. So at Children's, we have very clear guidelines for teaching in surgery, things that we expect the resident to be prepared for. They have to show us that they're prepared for the case before they're allowed to do anything. We're right there with them and constantly guiding them, but giving them the right amount of autonomy so that they can be successful. And then always feedback and learning, as we're doing the simple parts of the case towards the end, sewing up the skin, putting on the cast, saying, okay, what went well, what didn't go well, what could I do better as a teacher, what could you do better as a learner, so that we're constantly learning in the moment.
Got it. Thank you. And this is a question for you from the Q&A. So Melissa is asking, how much time do you spend on emergency cases versus planned procedures?
So that varies widely within orthopedics. And one of the fun things about orthopedics is that within that field, you can have vastly different subspecialties and lifestyles. So somebody who does, say, total joint surgery might never do a single emergency case. They might not take any call. They might field phone calls from home if a patient has a question, and that's it. As a hand surgeon at a level 1 trauma center, which is, a designation from the government where the most acute cases go into the ER, I am responsible for cases that might happen in the middle of the night. I would say that's a very small percentage of my practice. The vast majority of things happen during the daylight hours. And then within hand surgery, there's a lot of like semi-urgent things. So next Friday, I have only 2 cases right now on my schedule, and I'm sure that that will be filled with kids who will break their fingers and their forearms and their elbows between now and then. And so, it's not an emergency, but that does take up, I would say, even 15-20% of my personal practice is things that happen like within a week.
Got it. Thank you for sharing your schedule with us. And so now, what advice would you personally give based on your experiences to a high school or a college student who is interested in medicine and potentially a surgical career?
So I think if you're interested in surgery, I think again, there's not a lot of like hands-on experience that you can have as a high school student. But as a college student, potentially shadowing, getting to visit the hospital, see what a clinic is like, see what a surgeon's life is like, and then really thinking about your own personality. I would say the biggest difference in surgery is that direct responsibility. So, bad things can happen in the OR, and as the surgeon, you're directly responsible for that patient who's under your care in a way that I think really not other specialties are not like in the moment like that. And so I think having an understanding of whether and that may be hard as a high school student. I don't think I even knew I wanted to be a doctor in your shoes, but as you learn about yourself throughout college, learning what level of responsibility you're comfortable with, I think is very important if you're choosing surgery as a career.
Yeah, thank you. Yeah, that's definitely a large part of being a surgeon, and that's definitely something to consider. And so similarly, on a similar note, what skills do you think are both necessary and important to succeed at some of the positions you've held or through some of the experiences you've had as a surgeon?
So one of my mentors in medical school told me that he could teach a monkey to operate. And I think that people get hung up on the mechanical skills. And I think that that is something that anybody can learn. So when you're a surgical resident, we will teach you how to operate. I think the skills that you need are more of the softer skills that are harder to teach. So communication, a good bedside manner is all about communication and connection. Like Dr. Meyer was talking about her patients as her partners. We're in this together for a surgery, and you're going to know that person very well. I think those communication skills are very important. And the other thing is the leadership skills. So there's a lot of research that has been done. Atul Gawande writes wonderful stuff. If you guys have read anything that he has written about leadership and surgery, and when that room is a very special place. There's just the people in that room working together on that one patient for however long the case takes, and the surgeon is in charge of that room. And so if you're mean to everybody, it's possible that somebody's going to withhold information. Maybe they have a concern and they're going to be scared to share it. Maybe someone's going to get nervous and not be their best. And so and at the same point, if you're too laissez-faire, like everybody have a great time and blast the music, maybe something that requires more detail and patience is going to get missed. And so that part I think is very hard to teach during a surgical residency, but is probably more critical than your technical skill, is your ability to maintain the focus in that room and get everybody working at their best, because the best outcomes are going to come when your whole team is working at their best.
Yes, thank you. And you mentioned this a little bit earlier, but how would you say you balance your personal and your work life, especially obviously being a surgeon and being a doctor is very time consuming and requires a lot of preparation. So how would you say you kind of manage those two aspects of your life?
I mean, it's always a work in progress. There is no such thing as balance. I think one thing that is great about being a surgeon is that you're in charge. So if I have enough notice, I can take any day off that I want. I can, go on a family vacation. I can go to a meeting. I can leave early that day. So my daughter's birthday is coming up on May 1st, and I don't have clinic in the afternoon because we're going to go hang out. Obviously, I knew that was coming up. I think it becomes more challenging when the things are close in. So somebody is sick, or there's a random, very important sing-along at school that the teachers didn't share with us until the week before. Those things come up, and I think it's important to have a good team at home the way that you do at work, so that other people, if there's something that I can't attend, my husband can attend, or our Danny can attend. And I think that way I'm able to sort of spread myself between work and home. I think it's very important to set boundaries as well. Work will absolutely, fit into any nook and cranny that it can find. And so for me personally, I think Dr. Meyer probably stays at work later than I do. I prefer to get into work super early when my kids are asleep and get all my stuff done, and then come home when it's still daylight out and be able to see them. So I think everybody has their own personal preference and the way it works for them. But the nice part, again, is that I get to decide. So that's something that's not always true in training, but once you get out into practice, you can decide.
For sure. And then, Dr. Mayer, I was wondering if you had any personal perspectives on this question of how to balance, your work time and your time at home. Of course, like you mentioned earlier, being a doctor is kind of all-consuming, and it kind of does require a lot of time and work. So is there anything you might share about this? I think you may be muted.
Yeah, so it's definitely a juggle, and requires a lot of good organization. As you know, my husband's a doctor too, and he does a lot of procedures and he takes a lot of calls. So his schedule is very rigid, and so we have to plan things very far in advance, and try to make sure that we are not both like traveling the same day and leave no one home. But I think you get all the help you can, and I'm lucky to have we have grandparents in town who often help out a lot with attending events and filling in the gaps, and also work with friends and other neighbors and other people to help out. It's a juggle, but it's worth it. And we can do it all. We can do our job. We can do it really well. We can take care of wonderful kids, and and also try to maintain all your friendships and other relationships. But I think it's a great point that the work can be very busy, and the work in a hospital never ends. It's not like everyone sort of gets to the end and they say, okay, we're done. We're all going home. Like, that doesn't happen. So you have to be in charge of your time and your priorities and say, okay, that's all I'm going to do for today. I have to leave now and go do a different thing. And then decide, what are those different things and what's important? Is it, going to go exercise? I'm going to visit a friend. I'm going to go to my kids' concert or sports event. So you have to decide what you're going to do, and then you craft your time around that.
Yes, of course. Thank you so much for sharing your perspective. I would now like to welcome our third speaker of the night, Dr. Alsan. Dr. Alsan is a professor of public policy at Harvard Kennedy School, who works as a physician economist focusing on health inequality. She graduated from Harvard University with an undergraduate degree in cognitive neuroscience, and later earned a master's in public health from Harvard, a medical degree from Loyola University, and a PhD in economics from Harvard University. She did a clinical infectious disease fellowship at the Massachusetts General Hospital and has returned to the Harvard community after serving on faculty at Stanford. She founded the Health Inequality Lab at the Harvard Kennedy School, where she studies the causes and consequences of global health inequality. In 2021, Dr. Alsan was awarded a MacArthur Fellowship. So, Dr. Alsan, welcome to tonight's panel. Thank you so much for being here and taking the time to speak with us.
Thank you so much for organizing this. It's an honor to be on the panel with these other women scientists, and I apologize for being late.
Oh, no problem at all. Thank you. So our first question tonight is, how did you become interested in public health, especially global health inequality? And what were the experiences and key experiences that led you to your current position at the Kennedy School?
Well, none of it was planned. I did not, I always had wanted to be a physician. So I guess lesson number one is, be open to what reveals itself to you. I always wanted to be a doctor. I'm not exactly sure why. I grew up in a big family, and I was always kind of the one that would catch the crow that fell in the chimney that would gross out other family members. So I kind of knew that I was okay with pestilence. But then it really was after college, I had an experience working. I spent a year working in an orphanage in Tijuana. I just felt like I was burnt out. It was kind of before the gap year became institutionalized. And I worked on I didn't understand it at the time, but I was seeing the effects of NAFTA, which is the North American Free Trade Agreement, or formerly known as that. And it was essentially, lots of factories that were on the border between Mexico and the US. And a lot of families were moving from Chiapas, from southern Mexico, from Guatemala. They were moving to this border area to try and find economic opportunity, only to actually realize that they couldn't care for their children. And so I was on the receiving end, just doing work in an orphanage. And that's actually when my boyfriend, now husband, gave me this book, Infections and Inequality, which was written by Paul Farmer, who recently passed away, was really a great physician, humanitarian. And I had kind of knew that I wanted to be a doctor, but that really cemented it. He worked a lot in Haiti and in South Boston and other parts of the world, delivering healthcare to the poor. And I thought, okay, this really solidifies it. I want to learn about medicine, but then kind of with this NAFTA experience in the back of my mind, I realized that I needed a little bit more in my toolkit, or I thought I did. And kind of very ignorantly, I thought, well, in order to cure sickness, you need to get a medical degree. So like a bad SAT analogy, I thought, well, in order to cure poverty, you need a PhD in economics. So that's how that came about. Clearly, I haven't cured poverty or disease for that matter. But that's where the interest and idea came about, of kind of combining those two. And the passion really came from, as your other speakers were saying, frontline experience, pivotal experiences, reading, mentorship from all different corners.
Thank you so much for sharing your experience. I especially love your comment about not always knowing about what you're going to do next. That's definitely something that I can relate to, and I'm sure many others can relate to. And so with that being said, how did you determine the next step at these times? And what advice would you give to us high school students about deciding which direction to go?
Wow. I'm so impressed with the younger women in general. So I feel just a little, I know this is a webinar, and the advice giving would be part of it, but I really do feel like your generation is just pretty phenomenal. I guess what I would say is really try and figure out what you're passionate about. I think 3 questions are, what are you good at? What do you love? And what will help others? And don't be afraid. I think, as Dr. Bauer was saying, like, even if no one looks like you, even if, they need to maybe even make some accommodations, because all the operation tables are for like 6'4". I mean, it's not a joke. Like, just as a total aside, one time my husband and I, he's primary care doctor, one time we were looking for like the primary care residency party, and we happened into this room where we're up, we're up to the waist on all of these big suits, and we're like, oh, we're definitely in the orthopedics party. So even if you have to, break barriers, people don't necessarily look like you, as long as you kind of check those 3 boxes. Am I good at it? Do I love it? If I'm not, great at it, can I get better at it? Do I love it? Does it help the world? And kind of keep that in mind. I think it's really important that you keep at it, because we really need kind of fresh blood. We need empathetic leadership. We need knowledgeable leadership. We need people that have, a lot of integrity. And I think your cohort, Windsor girls, this generation of girls, kids more generally, really, they have that, a lot of that. So it's very exciting.
Yes, thank you so much. I definitely think those 3 questions are a very helpful guiding place for a lot of people to start. So I know in your experience, you have a medical degree, you have your degree in public health, as well as the PhD in economics. So do you think in your case, the multiple degrees are necessary or recommended, I guess, to do global health or policy?
Oh, no. I will say this. I think so in economics, there's even this notion of just a signaling model, like the degree is a signal of underlying skill and things like that. So I think you can be very, very effective. And I do encourage, I think it was Dr. Mayer maybe who mentioned like getting into the clinic and things like that. I really think that, from a social welfare perspective, we have a shortage of physicians. I feel I kind of miss the consumption value of practicing, but I also think like really I should be practicing in some sense clinical medicine, because we really that training is so specific for being a physician to seeing patients, and if that isn't going to be some important part of your life, maybe again, it subsides over time, but if that isn't going to be sort of what excites you, then I really think there's so many other ways, and I'm sure many of you have explored them, of helping with our healthcare system. I know Dr. Mayer also mentioned like administrative burden. The United States has more administrative burden than any other country, any other OECD country. Our costs are 8% of healthcare cost is just paperwork. It's literally the consultants, the legal, the contracts, the coding. I'm sorry, I'm probably putting the other doctors into PTSD by talking about that, because they live that. And that's not medicine, but so who's going to change that? Economists could change that. Politicians could change that. Smart patient advocates. There's so many ways that you can actually shape our healthcare system, make it better, make it more fair, make it more efficient. And that's kind of outside of clinical medicine. Or if you think about the importance of social determinants of health, transportation, food security, having a good job, those are also key things. So who's going to make the union stronger, or who's going to make sure that moms have daycares and dads have daycares, so they can actually go off and work and their children are getting a good start. Like all of these things are really important for health, and they're kind of not necessarily traditional medicine. So I guess you asked me if I needed all my degrees. Of course, there's some cost fallacy. This is like after you've done it, you feel like, oh, it was worth it. I'm not totally sure. I don't know the counterfactual of where I would be without these degrees, but I definitely don't think by any stretch of the imagination, simply by getting a college degree, you're in an elite group in the United States more broadly. The majority of Americans don't have a college degree. So, I mean, even that is just something. So making sure you find out what you're passionate about, where you can make the biggest difference, so many ways, even just to affect health. I think it's really, really important.
Sure, thank you. And Dr. Alsan, this will be our last question for you, but what advice would you give to younger students, especially in high school, perhaps, who are interested in global health or health disparities?
Well, the habit of engagement, so maybe you can't, maybe you can't necessarily, and this is, I have to, TM Paul Farmer, maybe you can't, maybe your parents are not excited about you potentially going to some far off place and living and working and in a poor area thousands of miles away. But the thing about the United States is that we're essentially, and this is with apologies if I'm offending any sensibilities here, but I am also an economist, is like we are essentially a developed economy with lots of developing economies everywhere around us. And that's just because our growing inequality, which really has taken off since the 1970s. Income inequality is just, we're now back at Great Gatsby era inequality. And so you can see that, when you walk down the street. So it's all the same, humans are humans, taking care of people, getting involved, figuring out what you like, what's the best way to do it, whether it's literally in a different country, whether it's refugees in this country, or whether it's just, Appalachia or South Boston or wherever it may be. Like unfortunately, there's just a lot of need. And just building that habit and getting your brain kind of used to that. Maybe there's some neuroscience to it, but I think I think that's the most important thing.
All right.
In addition to studying, of course.
Yes, of course. All right. Thank you so much for all your answers and all your insights. We are now going to move to group Q&A. So first, I'm going to have a question for all of you, and then we'll look for some questions from attendees. So the first question for all of our speakers tonight is there anything you would have done differently professionally in your career so far? And so perhaps we can start with Dr. Mayer first.
Gosh, that's a tricky one because it's hard to really know if you do anything differently, if things would have ended up any different. Well, I will say at this point in my life, I am trying really, really hard to be very organized. Not that I wasn't before, but I think really just trying to stay on top of things, like responding to emails and, when people ask you to do things, assuming you have bandwidth for it, you do it. Not that I wasn't before, but I'm really trying hard to, say yes to people and try to get a lot done. I don't know if that's really the right way to answer your question, but I think we always feel like we can be doing more.
Yes, thank you. I definitely think that's a common feeling. Dr. Bauer, is there anything you would have done different in your career?
I think there's a lot of things I could have done differently, but nothing that I think I should have done differently. And I think it's keeping an open mind, the main research and clinical focus that I have is because at my first job, it was the easiest thing. Which is brachial plexus birth injury, taking care of kids who have nerve injuries from birth, was because it was the easiest thing that my first boss could give me to do. And she said, here, take this clinic and take care of these kids and learn about it. And that became, my favorite thing to do. So I think just having an open mind, there's maybe lots of other things I could have done.
Got it. Thank you. And Dr. Alsan, in your professional experience, was there ever a time where you would have done something differently, you think?
I think, yes, it's so many things. It's hard to know where to begin, but I think you know, either I heard this from a coach of one of my kids recently. Either you win or you learn. Not getting so down about failure. I mean, just sort of making my I'm losing a little bit of my medicine. When your nerve cell kind of resets, making that time when you recuperate, recover faster, because it doesn't do you any good. The past is the past. You always have to be thinking forward and learn from it and just keep going. I wish my reaction time was faster.
Got it. Thank you. And I think this was a question from an attendee for Dr. Mayer. Did you ever feel imposter syndrome or out of place, I guess, whether it was at your time at Harvard or Harvard's medical school?
Well, I think the idea of imposter syndrome, it's a really kind of catchy term nowadays, and it's mentioned a lot. And I'm not sure I totally buy into it because, nowadays in many of our fields, we're surrounded by wonderful, amazing, inspiring people. And it has been pointed out, increasingly more women, which is great. And, rather than in that environment choosing to feel like I'm not worthy or I don't belong here, I really focus a lot on celebrating my colleagues' accomplishments. And when they do well, I'm so happy for them. And we're in a team. So, like, I'm part of it too. And so I don't really try to interpret from that something about myself or my self-worth, but I really try to think hard about the work that we do is ultimately trying to help people and trying to improve the way we take care of cancer. That's our big goal. It's not about me. And really trying to focus on this idea of celebrating each other. And that's, sometimes I'll be at work and I'll be sitting, with my colleagues, and I'll just sit there and kind of look at them and be like, wow, these are like the most incredible people. I'm so lucky to work with them. And I really feel like that's a better place to live, rather than kind of having a feeling like I don't belong at this table. Because, like, you do belong, you're there. And finding a way to feel really comfortable about that and know what your place is and how to celebrate that, I think is a kind of a better way to go down the path.
Yeah, I totally agree with that. And so for Dr. Bauer, our question for you would be, how has the COVID pandemic changed the work you do, I guess, both in terms of maybe during the height of the pandemic, and what are some lasting changes that you see?
I mean, well, we still wear masks every day to go to work. I can tell you that. It was hard, I would say that the height of the pandemic, when everybody else I knew was baking bread and moving to their summer house, we were going into work every day because the kids were still falling down, and we still, it was scary. You were theoretically putting your own life at risk to take care of people who needed to be taken care of. Back before we had testing, we didn't, even in the beginning, we didn't really know about masks, no vaccines, it was a little scary. And it felt a little bit like we were, as doctors, I think, and healthcare professionals in general, like kind of abandoned by everybody else, who was working from home. That being said, I think some of the lasting changes have been good for patient access. So, for example, we had tried to do virtual visits and telemedicine at Children's for like 10 years before the COVID pandemic. And then all of a sudden in 2 weeks, we figured it out. And that has been really great. I see patients all over the world, and I'm able to keep in touch with them. So there's a child that I operated on before the pandemic who's from Kuwait. And I kept in touch with them through the whole thing. He just recently came back for a visit because they were able to come back to the US now. And it was like greeting an old friend, you know, because we'd stayed in touch over telemedicine. And so I think some of those things we really pushed the fabric of medicine to take better care of patients, you know, who aren't right here with us. But you know, I wouldn't do it again. Maybe that's something I wouldn't do that. I wouldn't change that. I wouldn't do that again.
Yes, for sure. All right, so our last question of the night will be for Dr. Alsan. This is also from the Q&A. So could you describe a little bit about what your weekly schedule looks like and when you say like quote unquote, you're going to work, what does that look like? Are you doing research? Are you like making policies? Are you like teaching classes? Like, what does that look like?
Yeah. Well, so yesterday was a pretty typical. So I have, I'm teaching, I teach, or we could do, I teach mostly masters and some undergraduates, but also PhD students. So yesterday I taught lobbying by request to the MPP. These are masters in public policy students. And it's a core class. The first half of it, they learn microeconomics. The second class is on policy. And one of the things that I love, and this is why I really want to encourage all of you to just stick with it, find a passion, go do that thing, is because some of them came up to me, one girl in particular, and she was like, I never knew how much I loved economics. I didn't know it could be this way. Because I was really challenging them, you know, don't be intimidated by it. Ask yourself, is this really health insurance or is this a health system? You know, and we're solving one market failure, which is that, you know, research and development generates a positive externality, which is with another market failure, which is like putting in patents and creating monopolies. So like this for them was such a cool way, I think, for them to engage with. So I think so much of the time economics is sort of anyway, like it's a Bible that doesn't change. In fact, it's created and destroyed by people, and so that was really cool. So my last class was yesterday, office hours, couple of hours for meetings, including with a researcher from Microsoft. Then I had a call on, we're doing this project on systemic discrimination in healthcare. Then I went to see a talk by someone from U of C on estimating the elasticity of demand for firearms. And then we had a dinner. So it wasn't totally intern hours, but I think it was like a 7 to 9 day yesterday. So that's kind of, but it is much more flexible, I would say, than, you know, than at least internship, residency, fellowship. Attending is, you know, has a lot more flexibility in terms of like setting your schedule and stuff. And then academia has more flexibility when you're not necessarily teaching. So outside of like just like another form of teacher.
Yes, that makes sense.
Not too much information. I should
Oh,
have my
no,
Google calendar open.
that was great. Thank you so much. No, that was super helpful. So that was a lovely responses from all our panelists. Unfortunately, due to timing, it does look like we are going to have to end things here. I just want to give a huge thank you to all of the speakers who came here tonight for taking time out of their extremely busy schedules. And I also want to thank all of our attendees for coming and getting to hear from our speakers. I just want to share this QR code with everyone one last time. This is the QR code to the STEM Connects website. So if you want to stay updated for future events and future webinars, please scan the QR code or visit this website, and we hope to see you in the future. So just another big thank you and have a lovely night.
Thank you.
Thank you.
Bye.